Hello, everyone. I'm going to dive right into it. So today I'm going to talk about artificial intelligence in psoriasis, what the field looks like. And no matter how you feel about artificial intelligence, hopefully you can take a bit of nugget of this with you today. Here are my disclosures. So today we're going to talk about AI in psoriasis in terms of evaluating psoriasis severity as well as predicting treatment response. We're also going to talk very briefly about generative AI as well. But first, I want to ask you a question. So think about your childhood when you're playing games with your sibling or your parents or your friends or by yourself. Which game is the oldest? Is it chess? Is it blackjack? Is it Go, or is it Monopoly? Go, yes, I heard someone, yes, it's Go. So Go is one of the oldest games in the world, and the objective of Go is very simple. You want to surround more territory than your opponent. But what's unique about the game Go is that there are 10 to the 170 moves. And the number of moves in the game of Go is greater than the number of atoms in the entire universe. And therefore, Go cannot be solved by brute force or be predicted. However, in 2015, DeepMind published the first scientific paper describing this artificial intelligence called AlphaGo in Nature. And what did AlphaGo do? AlphaGo learned through reviewing and playing millions of games, and it reviewed how humans play the games. So let's put AlphaGo next to the world's Go leader, which is Lee Sedol, in 2016. AlphaGo beat the human 4-1. So this was a seminal time in our history. However, the next year comes the new AlphaGo. They call it AlphaGo Zero. I would have called it AlphaGo 2 just to reduce confusion, but they call it AlphaGo Zero. And the AlphaGo Zero learned to play with no human interaction and no historical data. In essence, it played by itself, and it started to create knowledge without any human interactions. And how did AlphaGo Zero do versus the first generation? It beat the first generation 100-0. So the next time when your teenager locks him or herself in their room with no human interaction, maybe they're onto something. So in 40 days, AlphaGo Zero essentially surpassed over about 3,000 years of human knowledge. So we want to rethink intelligence. If we think intelligence is everything contained in this particular circle, perhaps human intelligence is only a very small part of this intelligence. Now, let's talk about psoriasis and how AI is changing the field of psoriasis. First, let's talk about measuring psoriasis severity. Can AI measure psoriasis severity as accurately as Dr. Merola? Well, when we look at the different components of erythema, induration, scaling, and BSA, let's take a look. So this is research from a Chinese group looking at how one can take various photos of the skin lesions from different views. And you can actually aggregate these different views, put it through a heat map, and it will generate a score for the erythema, induration, desquamation. And if you look at how it did compare to human raters, the AI PASI score is the red line. So what you see is that it's actually very similar to how the human raters have done. So in fact, when they look at these statistics, they found that AI performed better in erythema assessments than humans. It all performs similarly in induration and scale. But there are limitations. It's hard to image covered parts such as the scalp or the genital areas. What about body surface area assessment? This is a study from Professor Li Wei's group from China looking at using artificial intelligence-based models to measure body surface area in psoriasis. And what's neat about this is that the clinicians can use it and the patients can use it as well. Can take pictures of the psoriasis lesions and then it can calculate a score for you. So the patients can actually use this to perform self-assessment. So here are the initial raw images, and then if you see these gray parts are where the AI picked up where the psoriasis lesions may be. Here's a different study from the Japanese group, looking at also how we can take these photos and convert them into this heat map-like output, and that can assess in terms of a more accurate assessment of PASI scores. Now let's pivot, talk about the second part, which is predicting response to therapies, something I think we're all very interested in. This is a study I had the pleasure to be a part of as a global effort, looking at predictors for PASI 100 response in this cohort. And instead of a hypothesis-driven research, which we are taught to do, this is a hypothesis-free research where we wanted the data to show us what it wanted to show. And what was found is that patients who had no nail psoriasis and no history of hypertension actually had a much greater chance of achieving PASI 100 at week 12. Any other advances in this area has to do with predicting therapeutic response. Here we're looking at the ability of using RNA biomarkers through more refined AI models in order to predict which therapeutic modality may be most appropriate for our patients. This is a different study from the Danish registry, and this is through machine learning models where you can predict biologic therapies for psoriasis. This is quite neat. So if you pick a therapy that your patient is on, and you essentially draw a line up there, and you get the number of points, then you come down and grab another characteristic, whether bio-naive or not, draw another line, vertical line straight up. So you would add up these various points, and then you come here, you put the sum of your points down here, and you can draw a vertical line down, and that will tell you the likelihood of the patient will stay on the biologic. And then here, similarly, we have this from Huang et al. Looking at predicting the chance of relapse post-biologic discontinuation. And through these machine learning algorithms, they're predicting that a patient having anxiety and the factors such as time to PASI 75 and maximal PASI response are predictive of whether they're more likely to experience relapse following biologic discontinuation. Similarly, in this nomogram, you can essentially put in the different characteristics, go up, find a number, and you add the different points, and then put it here in the total, and then come down to see what the likelihood is. And you can plot that also on this Kaplan-Meier curve there. What about psoriatic arthritis? Dr. Merola mentioned that earlier. There are also predictive modeling that is being developed to look at identification of the various risk factors. And here's a machine learning approach looking at the importance of various factors in terms of predicting remission, identifying, for example, DAPSA at baseline is most predictive of remission. And I'll finish in my last 30 seconds to talk about generative AI, which is ChatGPT. How many of you use ChatGPT currently? Okay, so each year I see more and more hands go up. So I think based on my very scientific poll here, it's about probably 87% of you. So several tips to take your prompts to the next level. I've created this acronym called PASTY. Perspective, you want to define your perspective, define your audience. The more specific, the better, and that you can tell it to say it in different tones. And then iteration is key. So if it spits out something you don't like, you tell it again. But prompt technology is getting so good that these days you don't really have to be honest, spend too much time in terms of thinking about the prompt. But how good is AI at diagnosing psoriatic disease? Let's take a look at this. What is this? Intertriginous psoriasis. So back in December 2023, if you were to put this in AI, it would say this is a close-up of a person's lower face and neck with visible skin lesions. I don't know what person that is, but that was interesting. However, 7 months later, it identified it correctly as intertriginous psoriasis, parentheses, inverse psoriasis. However, a year later, same image, it shows that this is contact dermatitis. Interesting. It got better, then it got worse. So it really highlights some of the perils of using AI is sometimes garbage in, garbage out. But very importantly, one of the limitations is that it can hallucinate. That meaning that it can make up stuff, and it will make up stuff quite convincingly, and it will give you citations that do not exist. So we want to keep those limitations in mind. And with that, I want to thank you very much for your attention, and thank you for not hallucinating too much during my talk. Thanks.
All right, thank you, April. That was incredible. So our next speaker, Dr. Laura Savage, who is, I think, you're a co-vice president currently of GRAPPA. I'm trying to remember our detailed org chart in my mind. Another dear friend and colleague of many years, who's going to be talking about addressing mental health and psoriatic disease. I think this is a tough one. We're looking forward to hearing from Laura. I think we're making some progress now on some of the comorbidities, including obesity. This one, to me, continues to be a big challenge. So, Laura, thank you for addressing this. Careful.
Thank you very much indeed, Joe, and good morning, everyone. It's lovely to see you all here in Paris. So yeah, 10 minutes to cover mental health, Joe. Yeah, I'm hoping you're not going to fix it or solve it in that time, but I'll try my best. So it needs no introduction to members of GRAPPA here in the room about the psoriatic margin. We know that people with a predisposition to developing psoriasis have skin and then subsequent systemic inflammation. Typically, we think of that within the cardiovascular system, but of course, we also know there's a degree of neuroinflammation as well. And so we see the development of comorbidities, and we mustn't overlook the psychiatric comorbidities, which lead to several consequences for patients in terms of their quality of life and also their burden of disease. And so patients often will have maladaptive coping mechanisms. They will be more likely to smoke, consume high levels of alcohol, and have problems with obesity. And so we understand now more about this complex interplay between patients with psoriasis and their levels of anxiety and depression, where there is persistent psychological stress. And patients also have a degree of alexithymia, so they find it very difficult to communicate with you as their health giver, as their healthcare provider, as how best to communicate the impact of their disease. We also see that many patients, to give relief to their anxiety and depression symptoms, will drink alcohol, but that in turn leads to increased systemic inflammation. They're more likely to smoke and have poorer treatment compliance. And so we see this ongoing complex interplay. Unfortunately, we don't have a huge amount of time to go through some of the pathophysiology of the brain-skin axis, but this generally just shows how the stress that patients with psoriasis may experience will exacerbate their psoriasis through several pathways. We see there's alteration in both central and peripheral hypothalamic, pituitary, adrenal axes. So you can see there high levels of cortisol production leads to sympathetic nervous system activation. That in turn leads to mast cell degranulation and increased pro-inflammatory cytokine production. And it's this feed-forward loop that we're seeing. There is also, as you can see, peripheral effects as well, directly through corticotrophin-releasing hormone on the skin itself. And so patients present with multiple comorbidities. We see more patients, around a third, are likely to misuse alcohol and have anxiety and depression related to that. We mentioned about alexithymia, so they'll find it very difficult. When you say to the patient, "How are you?" they'll often say, "I'm fine, thank you, how are you?" and deflect it back. And so we have to really build that rapport with these patients so they feel comfortable and confident. And it may take sometimes even a year of seeing a patient before they'll feel comfortable to disclose the true impact of their psoriasis. Around a third of patients will experience anxiety and depression. So again, it's a call to action to everyone here to screen our patients at every touch point. And up to 10% of your patients, 1 in 10, that's at least 1 per clinic, may have contemplated suicide. And interestingly, we can see how stress can also influence treatment outcomes. And there's a nice study demonstrating that pathological worrying can lead to slower clearance of psoriasis for patients receiving PUVA. The concept of CLCI will be familiar to all of you. So this is looking at that cumulative life course impairment that is not just the physical comorbidities, but also the psychological comorbidities, the stigmatization, and their coping mechanisms, which all feed into a patient's trajectory in terms of their full life potential. And many different groups and organizations have now recognized this and included it within their guidance, saying how we as dermatologists need to implement a long-term strategy to try and reduce long-term suffering for patients and reduce the escalation of CLCI. So we meet here today here in Paris. So this is a call to action for those of you in the EU, and you may or may not be familiar with this document called Healthier Together. So the European Commission had published this document in 2021 that spans through as a strategy through to 2027, which is the EU Non-Communicable Diseases Initiative. And this is designed to support those of you in EU countries in identifying and implementing effective policies, but also actions to reduce the burden of non-communicable diseases. And the 5 topics that were covered by this initiative, you can see here, and I think 4 out of 5 of these specifically relate to our patients with psoriasis. So yes, we're used to screening for cardiometabolic disease. We've heard from already earlier about the benefits from Ken about GLP-1s, weight loss and so forth, and we need to support our patients to make better choices in terms of diet, tobacco use, alcohol, etc. In the UK, we also have an initiative called Make Every Contact Count, and this is something that, again, I appeal to all of you to do in your clinical practice. So this was an approach to behavior change that is using the millions of day-to-day interactions that organizations have with people, trying to support them to make positive changes to their physical and their mental well-being. And it's not designed to interrupt and slow down your consultations. It's just saying it takes a matter of minutes, not going to add to your workload, but just at every time point, if you take the time to ask patients about their well-being and some of their lifestyle choices and offer them and signpost them to support mechanisms, then you may have a better chance of supporting those patients. Multiple ways in which you can do that. So an opportunity at every time point is to use screening questionnaires. In my center, patients come in and before they see us, they do DLQI, they do PEST, and we also do PHQ-9 for depression and GAD-7 for anxiety, which are really straightforward. The most important thing with any of these questionnaires, of course, is not just to add up the score and document it, but to look at the answers and identify where the patients are struggling and use that as a springboard to have those conversations. HADS is a similar opportunity. You can see this often in clinical trials, HADS A, HADS D, and again, you've got the different brackets there as to severity of anxiety and depression. And suicide, of course, is something, as I've said, that 1 in 10 patients may contemplate. It can be difficult to have those conversations, but it's really important to do so. And there are questionnaires which allow you, if you find the conversations more difficult, to facilitate the discussions, which go into a little bit more detail. Those of you who've been doing clinical trials will be familiar with the Columbia Suicide Severity Rating Scale, but again, can be a very helpful way of just understanding how a patient is feeling with regards to suicidality. But of course, I'm sure many of you here in the clinic will agree with me that you are sometimes fearful in a busy clinic of opening Pandora's box. And Pandora here is allowing all the evil to flow into the world. And I thought that was the end of the myth. But when I looked into the Pandora's box story in a little bit more detail, what I found actually was at the bottom of that box, there was hope. And Pandora closed the box, or the jar if you're a purist, and actually hope remained. And so when patients come to us, you are their source of hope. And so we have a need to treat patients with tight disease control. We've heard from Joe already about how they're approaching that in patients with psoriatic arthritis, and we need to follow on from our colleagues in rheumatology, adopting a treat-to-target approach in psoriasis. And that's thinking beyond just clinical targets and safety, but thinking about treatment satisfaction, health-related quality of life, and also this concept of aberration of systemic inflammation, particularly with regards to the nervous system. This is a nice prospective multi-center study performed in Germany, where they were looking at patients who were under treatment for psoriasis and having various treatment modalities, and they were screened for depression symptoms with the revised Beck Depression Inventory, or BDI. GPs were asked to intervene and support patients and arrange further evaluation for any signs of depression, and then they evaluated that mental health provision after 12 months. And what you can see here, if patients' PASI scores over that time increased, then their depression symptoms increased, and if their PASI scores decreased, then their depression scores reduced. So they did a regression analysis looking at the different factors to predict a decrease in the depression scores. And you would think, actually, that things like psychiatric treatment received might be the reason why their depression scores reduced. But actually, the only significant variable that was identified was the difference in PASI score. So this is a call to action to you to really tightly control your patients with psoriasis. We are so fortunate to have a plethora of different, very advanced and effective treatments for our patients, but so many patients are still not accessing the care that they deserve. It appears that all interventions are effective for psoriasis in terms of reducing levels of depression and anxiety, but as you can see here, this is better for biologics than orals, and that's also been replicated in the SOLAR registry as well. Pretty much most of the biologics have now demonstrated improvements in symptoms of depression, and also we have seen some head-to-head analyses as well, with guselkumab showing greater improvements than adalimumab, and risankizumab showing greater improvements in depression and anxiety compared to ustekinumab. Simple guidance from the Uruguay Derm guidelines, simply saying that we should be screening and asking our patients about anxiety and depression. And then there's also some suggestions around alternatives to brodalumab and apremilast, the nuances of which are out of the time and scope of this talk. In terms of things we can do, we need to signpost our patients to education, to self-help, and support groups as well, and that will be very much dependent on your local individual levels. But there is good evidence to suggest that CBT can help patients with psoriasis, medications such as selective serotonin reuptake inhibitors or other antidepressants, and also close interaction with mental health services. In homage to April's talk and ChatGPT, patients are actually utilizing these AI chatbots more than Google in many instances now. So I asked ChatGPT last night, where can I get psychological support for my psoriasis within the UK? And you can see here it's come up with a range of different psoriasis and specialist-related support services, signposting with links to various clinics that have psychodermatology services as well as support associations. And it also goes on to link other support services that patients can access, such as IAPT in the UK. In our centre, we sought forgiveness rather than ask permission to get a psychologist. It took us a lot of time, but we did get funding from a pharmaceutical company, and then we were able to demonstrate the benefits in our patients with inflammatory skin diseases, which then enabled us to receive ongoing funding. Pharmaceutical industry as well, and generally looking at measures to support patients, realizing that there is a paucity of funding for in-person psychological services. There's an example here about the Claro app from Amaral, but others are available where they're partnering with apps such as Happify. And then finally, mindfulness. Interesting studies looking at mindfulness in patients with psoriasis. And you can see here in this study from Brian Kirby's group, you've got a control group, patients without psoriasis, and then those receiving mindfulness-based cognitive therapy. So that's the green line. You can see how total self-compassion increased, depression, anxiety, and worry decrease. And then, interestingly also, it appears that the aging process may be slowed as well by doing mindfulness. So a little bit of food for thought there in terms of reducing telomerase activity. And so with that, I'd ask you to close your eyes, take a deep breath in, and be happy, healthy, and zen here in Paris. Thank you very much.
Thank you, Laura. You'll all be happy to know I scored a 21 on that anxiety score that you showed a moment ago, so not looking good for me. All right, I'm delighted to bring up Dr. Alice Gottlieb, who really needs little introduction, dermatologist, rheumatologist, true world-renowned expert in psoriatic arthritis, all things psoriatic disease. I'm fortunate enough to have her as a colleague now, so professor of dermatology at UT Southwestern in Dallas, and she's also relevantly the founding president of IDIOM, which I think you'll hear all about in her talk. So thank you, Alice.
Thank you. Thank you for inviting me for that lovely introduction. I'm going to be presenting work on using the patient to tell us whether they have psoriatic arthritis with some probability and whether they're in target range. And this represents the work of the first 4 people here are trainees. and so it represents their work. My disclosures are here, and as I say many times, my number one disclosure is my mother of blessed memory, who had psoriatic arthritis and was greatly helped by one of the drugs that I helped develop. Okay, so I couldn't emphasize this more. It is really important for dermatologists to get involved with psoriatic arthritis. Psoriatic arthritis is common as a comorbidity of psoriasis. In most cases, it's not hard to diagnose. And so what if we make the wrong diagnosis and they get their rheumatoid arthritis or osteoarthritis or gout treated by a rheumatologist? They need a rheumatologist too. And you don't want to miss the diagnosis because it's disabling. And it's really a shame that it goes undiagnosed in about 40% of cases. And we have plenty of years to figure that one out because the skin disease precedes the joint disease on average by about 10 years. So we are the first ones who can detect psoriatic arthritis. And why does it matter? Because we can do something about it. There are a number of TNF blockers, there's interleukin-17 blockers, a JAK inhibitor, and now possibly even an IL-23 inhibitor that inhibits radiographic progression. And so, so we can actually do something with an early diagnosis of psoriatic arthritis, and it's been shown that if you don't do something about it, you do get more disability. And so I don't know how you can treat psoriasis if you don't know whether the patient has psoriatic arthritis. Although psoriatic arthritis is more common in people with more extensive skin disease, you could have people with very little to no skin disease who have psoriatic arthritis.